Okay, you guys, I'm going to try to update and be not such an elder millennial, but maybe a younger one that knows a little bit about tech. So we'll see how this works. Let me know about the format, if you hate it, if you like it, and we'll modify going forward. There's several things that have come up in the last couple of weeks since we had our corporate meeting. First of all, sterile processing asks that we throw away our sharps before we send the suture kits down. I think inadvertently there have been some suture needles that have gotten caught up in the suture kits and then are sent down to sterile processing, and their workers are worried about needle sticks. Fair enough. So make sure you throw away your sharps prior to the tech collecting the suture kits and sending them down. Secondly, Dr. Rowe is a colorectal surgeon in town. He does do some surgery and some colonoscopies. And lately he has been getting, or there was one instance where he had some post-procedural bleeding, and it wasn't anything really significant, but he is different than the GI guys. And so the GI guys don't have a formal cross coverage agreement with him for call. And so as a first line, if you get a Dr. Rowe patient with a complication, if you would call the answering service or Tiger text Dr. Rowe and get him involved preferentially. Now, if for some reason he's not calling back or there's some kind of issue there, you can always revert to the on-call as an emergency backup, but it should go to Dr. Rowe first. Third thing, when you dispo an SCC patient, so the Sierra Conservation Center, the prison, when you dispo them, whether it be admission or discharge back to the facility, they do request that you let the on-call doctor know. So our techs now have the phone number and the information and can get you in contact with the doc. We are becoming or trying to get certified to become a stroke ready center. Which means that basically we're following current guidelines and practices with our CT times and our thrombolytic times and all that. What this stroke certification is going to do for us, though, is that in order to be stroke certified, or stroke ready center, certified ready center, we actually get a teleneurologist access to be able to help us make those decisions about thrombolytics, etc. So that will be super helpful. We do need a stroke medical director. So far it's defaulted to me and I'm fine doing it and going to the meetings. But if anyone has a passion for stroke and wants to be involved and do it, I am more than happy to get you connected in to be part of it. So let me know if you're interested. If not, I'll just keep plugging away and go from there. Pretty soon, I do want to send out the EKG overread process. We have committed to the Medical Executive Committee that we will have a quality assurance process going. And so my idea is I'm going to kind of send you a buddy for maybe a couple of quarters to where you can read several of theirs every month. And then we will just keep a log and keep track so that we can show the medical staff office and the MEC that we are doing our due diligence to ensure that we're creating quality reads. We have a new gonorrhea chlamydia swab that also checks for trichomonas, and it does run on site, and the results will be available in less than 24 hours. There are a few excluded populations. Male urethral swabs can't be done. I don't think it's approved for use in less than 14-year-olds for GC chlamydia component, and I think it's not approved for the trichomonas component if you're less than 18 or if you're a geriatric patient. I don't think we come across that all that often. It would just require a different swab. But the 3-in-1 it seems like a pretty good deal. So that is that is already live. I'll try to put a picture up in the doc room so that you guys can see what the swabs look like. Next on the agenda here, if you insert a central line, I do need you to put that you use the central line insertion bundle. And basically that's just saying you use sterile technique, you used whatever, the full barrier that you put on your biopatch, etc., etc. There is a dot phrase. It's central _line _placement. Or if you want to steal Stephanie's, I'll include that in my email. It's just stuff that you're already doing. We just have to make sure that we document it, because if there's any central line infections, if we don't document that, they're going to come back and be like, you guys caused this because you didn't use barriers. But I'm sure that you are, because we all have learned to do that. And if you're not, it's time to start. And then when you place a central line, sometimes we are drawing off cultures and giving them to the nurses, because often it's because it's a super sick patient and maybe they couldn't get good peripheral access. However, they're asking that we actually don't draw blood cultures off of that central line, because the nurses have very stringent blood culture draw protocols. And so sometimes there's some contaminants getting in, and it's causing some issues. So the nurses know now not to ask for blood cultures off of that central line. Obviously, if someone comes in with a chronic indwelling line and they're septic, you'll get your culture off of that. That is expected. But as you're putting in the central line in the ED, don't draw cultures off of that. There are some primary docs that have sent me a couple of cases of COVID where the patient could have gotten Paxlovid, and sometimes I can't tell if it's just not being thought of and kind of being missed, or if we're just not documenting that we had a conversation and the patient didn't want it. But make sure that you are having that conversation, so that it's really clear, that the patient got the option. And then I guess it's just a matter of documentation. So if you guys will document and so that we can kind of track that, and so the primaries know what discussions have been had. We are getting a new urologist. He should be starting in the next few weeks here. They are having a lunch with him in a couple Mondays from now. And so someone from the ED team should show up, and someone from the hospitalist. I'm happy to go, but if any of you guys want to meet the new urologist, ask them any questions, feel free to reach out. I'd love to have you join us for lunch or to go in my place. So it's really exciting though. So now we'll have 2 urologists, and we hired up a couple of urology PAs. And so there may be kind of a shared call model where the PA will be the first call that we make, and then they'll kind of field it and help where they can, and then kick it to the urologist if need be. So we should be getting better urology coverage, which I am super excited about. One last thing. Dr. Maraj has started practicing again. And there is a little bit of confusion about when we should be calling him, if he's on call. So I'm working to clarify that. In the meantime, Dr. Davidson has reached out, and she asks that previously, if a patient was seen by Dr. Maraj and had been established with them, that was under the umbrella of the current cardiology group that contracts with the hospital. If they've since reestablished with Dr. Maraj and they're actively being seen by him, that would likely be considered a Dr. Maraj patient, and you can reach out to him as the first call. But if they haven't reestablished, it's actually more of a Adventist health cardiology, like a Dr. Davidson cardiology group patient. And so go ahead and call that team first. Again, I'm going to clarify more in the next week or so with who we should be calling, who is actually in charge of the cardiology patients, because there is a little bit of confusion just now. But I'll keep you posted. Let me know if there's any problems. Also, Dr. Stewart has asked us to let her know if there's any problems transferring patients to Dameron, which is an Adventist health hospital. We are going to start leveraging some of our connections a little bit more and try to streamline it and make it more like a system where we can share resources, etc. Dameron will be working with our cardiology group, for our STEMIs and things, and if they have to go for emergent PCI or need CT surgeons for any reason, or excuse me, not emergent PCI, but emergent CABG, they will have the CT surgeons, and so we're starting to create some inroads with them. And so let us know if you have difficulty transferring to Dameron. I do need the MR numbers, and I will pass them along to administration. I think that's my big list of things. Hopefully you hung in there for a good 11 minutes. I'll try to make this more interesting next time, and please let me know about the format, and please take 11 minutes to listen to our ED updates. Thanks so much. Take care.